Well, good morning, everyone. Thank you for joining this morning's Fireside Chat, and welcome. This morning, we're joined by representatives from RUBICONMD who are going to share their vision for integrating behavioral health and eConsults as part of comprehensive care. As behavioral health concerns continue to rise during the COVID-19 pandemic, supporting primary care with tools and resources to treat the whole patient is an increasing top priority. RUBICONMD has expanded beyond foundational eConsults and launched new resources within the platform to support PCPs and behavioral health conditions. This morning, we're joined by Sarah Alexandra and Nicole Diener from RUBICONMD. Sarah serves as the Chief Operating Officer of RUBICONMD and is responsible for the delivery of eConsults and client success. Prior to joining RUBICONMD, Sarah served as a market operations lead for Lumeris and managed the population health partnership with Mount Sinai Health Partners. Sarah led the team responsible for engaging providers in the transition to value-based care, as well as implementing the technology platform that drove all population health initiatives. Prior to her role at Lumeris, Sarah was an executive partner with the advisory board company in the revenue cycle division. Across her 12-year tenure, Sarah worked with multiple health systems, academic medical centers, large clinic networks, and community hospitals on revenue cycle improvement opportunities. Sarah holds an MBA from Georgetown University and received her undergraduate degree in anthropology from New York University. Also joining us is Nicole Diener, who's a Senior Director of Behavioral Health Solutions at RUBICONMD. Nicole is an MSW and spent the first decade of her career providing direct mental health services to children, women, elders, as well as advocacy in the court system. Over the last 18 years, she has worked within a variety of leadership roles, building products and services to support primary care networks to evolve their care models and improve patient experience and outcomes. Nicole also helped to build and lead the Colorado statewide implementation of the Comprehensive Primary Care Initiative, as well as a statewide family medicine residency collaborative to improve residency training and education around primary care transformation. During her most recent tenure at Care Allies, she built a practice transformation service line that has proven results for independent practices and improving their quality and cost outcomes. With that, I'd like to hand over to Sarah and Nicole, who'll share more about Rubicon's approach to integrating behavioral health, and we'll take questions from participants.
Perfect. Thanks, John. We're so excited to be here this morning. So thanks for starting the day with us. I think we're looking forward to the discussion, and I know there's a great agenda planned with Blue Path across the day today at the eConsult workshop. As John mentioned, my name is Sarah Alexander. I serve as the Chief Operating Officer of Rubicon. And as John mentioned, I have a pop health background. And so when I joined Rubicon, I was really focused on trying to get to the bottom of how do we think about driving providers to use eConsults and really leverage technology and care delivery. And that could be anything from aligning for different clinical initiatives that might be underway, looking to integrate into referral or in further integrations with EMRs. So I spend the bulk of my time trying to think about different creative ways to make sure that we're driving adoption and really recognizing the value of eConsults. I also spend a fair amount of my time trying to figure out what are the actual friction points that are preventing that from happening, and making sure that we're being creative with ways to reduce those friction points so providers are actually being able to deliver better care and faster care to patients. We also do a lot of work to try to make sure that we're staying on top of any pain points that might be happening within primary care in general. So some of those pain points have been long and some of them have been new. Certainly with COVID, they've introduced some new challenges. But I think what brought us to the behavioral health work is through all of our conversations and surveys, just dialogue with and user interviews with providers. Behavioral health, even before COVID, was always coming up as a top concern and one that we felt like we really needed to put pen to paper to try to help solve. So what I want to take you through today is just three things. I want to make sure we kind of give you all some insight as to what we heard was the primary challenge of behavioral health and primary care. We've aggregated some data and can give you kind of just a little bit of insight as to what we heard from providers. Two, As with all things, and I'm sure you all are feeling this on a day-to-day basis, COVID-19 has certainly exacerbated known issues across the board and across all aspects of healthcare. We wanted to offer just at least what we're thinking about in terms of COVID and next steps for healthcare and primary care from the Rubicon side. And then number 3, as John mentioned, we've already made some strides in terms of figuring out how to support primary care with behavioral health. So I want to give you a little bit of look as to what we've already done, and then also want to make sure that we spend some time just giving you kind of what we think the future is. And as part of that, I think John introduced my colleague, Nicole Diener, but just a quick word. We are super excited to have Nicole as part of the Rubicon family. She's recently joined the team, and I think as we started to put services and expand our technology to meet the needs of the behavioral health challenge, we recognized we needed to invest and make sure that we were bringing in subject matter experts. So super excited to have Nicole here, who's really helping us articulate what does the future service model need to look like for us. And so she'll give you guys a preview of that future going forward. Nicole, anything to add before I jump in?
Nope, go ahead. Thanks, Sarah.
Perfect. And I'm displaying my screen, so I can't actually see the chat function, but feel free to interrupt me. We have a couple of points where I'll pause for discussion and questions throughout the discussion. But just to dive in, for those of you that don't know Rubicon, we were founded about 6 years ago, really with the mission to democratize medical expertise. And I think what we mean by this is we really want to make sure that every patient, no matter where they are or who they are, gets access to the medicine that they need. And we want to actually innovate for primary care specifically to try to help advance those care plans. We work across a number of different organizations across the country. So we really work a lot with those organizations that are kind of innovating for primary care and are in some sort of value-based contract, total cost of care recognition. We work a lot with direct primary care, employer on-site health plans, and even in the correctional space. So some of you on the phone might be involved with this across the board here, but we're continuing to expand who we work with. We work with over 5,000 PCPs at this point across the country. And I think for those of you who are probably on the call today, you probably know and recognize the value of eConsults. Certainly we have been big proponents of this eConsult workshop to help kind of further that mission. Just a few things that we on the Rubicon side really hold ourselves accountable to is we do want to make sure that we're trying to have a seamless technology experience for the PCP, but we also want to make sure that these eConsults are actually educational and really driving care as much as possible. So we're really always thinking about ways to continue to do that, whether it be from a service perspective, again, deeper integration with technology, if that helps reduce friction points. But these are kind of the things that we hold ourselves accountable to when we look at our roadmap. And it's in this vein that, again, we spend a lot of time trying to make sure that we're listening to the providers who are using our platform, and we're trying to stay one step ahead of what they need and what we could be doing, which again is what drove us to start looking at behavioral health in particular. So wanted to give you guys a little bit of insight as to what we heard when we were actually speaking with providers about the challenge of behavioral health. Number one, there's ever-changing medication and treatment. And given the complexity of some of these patients that have underlying chronic conditions in addition to behavioral health concerns, it was the thing that kept coming up as top of mind for providers to say we really have to address it because it's hard to know what the impact on the total patient experience is and the total patient care experience. There's always been a challenge. Certain areas and certain parts of the country have more pronounced gaps in terms of access to psychiatrists, but it's certainly one that we would say we've heard across the board has been a challenge to actually meet the patient demand with a number of psychiatrists that we have across the country. The other that came up a couple of times was just a lack of support for population health. It wasn't a sort of a question of population health in particular, but it was just saying some of the models out there to address behavioral health weren't really designed to support kind of the whole patient experience. And again, Nicole will talk about this a little bit later, but it's one of the key things that we're trying to help solve for primary care is to think about the patient as a whole. And then again, given COVID-19, we had a lot of this work already underway before the pandemic. And as you can imagine, the pandemic has now really accelerated a number of concerns in being able to treat patients with behavioral health issues. We've done our kind of accept what we can service perspective, which we'll give you some visibility into, but we all recognize that this is going to be a short-term issue for providers. I'll give you a little bit of a look in terms of when we start back in 2019, at the end of the year, we actually took a look at all behavioral health eConsults that we had. There was over many thousands of eConsults that we kind of mined. And we looked at, number one, what were providers asking? What were the most prevalent conditions that were presenting? And two things to point out here. Number one, we were trying to think of behavioral health and recognize that there is a sort of continuum of acuity. So there's low acuity and sort of mild to moderate, and then certainly there's more severe acuity, all of which we think needs to be addressed in some form of fashion. But when we were starting to think about how Rubicon could support, we also tried to get a gauge of just how many conditions are we talking about for these patients. And overwhelmingly, half just had one behavioral health diagnosis, and then 90%, if you aggregate, had 1 to 2. So felt like if you were looking at depression, anxiety, even ADHD, those making up the bulk of the mild to moderate disorders, felt like there was an opportunity for Rubicon to do something here. If you also look at the bottom chart in terms of what we were hearing from primary care in terms of the total barriers, most of it was going back again to that lack of psychiatry or just so long to actually wait to see a psychiatrist. So it was sort of with this backdrop that we started trying to figure out, well, what do we need to do to help primary care? But before I get into what we're thinking about, I wanted to pause just to see if this resonates and just hear from the group if there were any other major concerns that you all were thinking about or dealing with from a mental health perspective that we could discuss this morning.
And participants should have the ability to just unmute themselves if they do have questions or comments.
Yeah, hey, this is Andy Patterson, and I'm with Autism Behavior Services. One of the biggest choke points, I guess, that we see is from a diagnostic perspective for people to be able to access care. And we see that, at all levels, depending on the funding sources that we're working with. It could be the Medicaid system, Medi-Cal, or commercial, that there's simply not enough licensed psychologists or with adequate access to be able to perform the diagnostic so that the behavioral components and services can be engaged. Do you have any thoughts or feedback on how that can be expanded? I mean, we're certainly seeing telehealth as an improvement, but it's still not a resolution. A lot of it comes down to, I think, some of the funding source levels that people are still, they're still at the back of the line because the funding source for them isn't commensurate with private pay for that particular industry.
Yep. Nicole, do you have a thought?
Yeah, and I apologize, Andrew. I was writing down some information from the chat. So you're talking specifically around access for a specific population. Can you repeat that part again? I apologize.
Yeah, access to care typically for the behavioral services we primarily focus on is applied behavior analysis, which is it is performed, yes, for people with autism, but it's also performed for a significant amount of other folks, from conduct disorder to I think you kind of said people that have multiple diagnoses in addition to autism, but it's not limited to that, especially with licensure across so many states. But where we're seeing oftentimes that access to care issue, and when we talk about more in particular autism, early intervention's key. And we still are seeing significant challenges with people being able to get diagnosed. And, and that is where we see, I remember, there's been some studies that show lower socioeconomic families typically are accessing services later because of those access challenges to the diagnostic.
Yes, so great point, Andrew, and I apologize that I got distracted for a minute by the chat. But essentially, yes, so we, RUBICONMD has been approached by a couple of different partners who are currently trying to address this issue, specifically to earlier autism diagnosis and intervention, knowing that the earlier the intervention, the better. We aren't specifically focusing on autism today, but it is on our sort of discovery roadmap. I also saw something in the chat around access to psychiatry, including pediatric. So a lot of our clients that we serve today are value-based clients who primarily focus on adults, but of course have pediatric patients as well. And then our corrections clients. So we're sort of focused on how to address the most needs around the adult population. But like I said, we do realize the autism gap, and we are looking at a couple of potential partners to try to help fill that gap, because we do understand that access is an issue, and there, like you said, for specific populations, especially those who come from low socioeconomic status, they go a long time without diagnosis and then an extended time where they don't get the right support. So thanks for highlighting that, and that's definitely on our roadmap.
Yeah, I think what we see is there are folks that can do the diagnostic, like a pediatrician and those types of things, but legally they can by the states that allow them to do that, but they're not comfortable doing it. So they will oftentimes prefer to refer them to a licensed psychologist. And I said that unfortunately that's I think where a lot of the challenges lay, is that a lot of them do private pay as their preferred work source, and obviously there's some significant financial discrepancies between what the federal government or the CMS has as their reimbursement levels, which makes private pay much more feasible for them to want to spend time for their practice. And so I guess that's hopefully, as like you said, you kind of develop your roadmap. I think that's probably the biggest challenges that we see when referrals are going out, is they kind of have those points where they just get stuck.
Yeah, no, I think that's a good point. And the vendors we've been looking at really try to intervene on that diagnosis using video and other tools to really help the PCP make those diagnoses earlier and not get into that backlog of waiting for a psychologist or another, more highly educated resource. So that's a really good point.
And some of it, sorry, if I could just add one more thing, if you guys, have any level of involvement with the states, because some of the states, what they've done is they've developed multiple additional courses that some of these folks have to do, and if they're already full and already have plenty of business, they're not motivated to want to spend another 40 or 80 hour work when they're already legally licensed in the state to be working. So just FYI, some of those states have added some barriers that seem to be excessive, and they have no motivation to want to do some of those additional pieces. So just adding that.
That's a challenge.
Thanks, Andrew. Yeah, we certainly can follow up on our progress as we kind of continue to think about autism. We have specialists that do, I know, are on the platform, but certainly something that we'll continue to build out as we think about a more comprehensive behavioral health program.
Thank you.
Appreciate the comment, for sure.
And Sarah, Wendy has also posted in the chat that she agrees with Andrew. And along with that problem is the availability of providers, which we know and are trying to address. So there's the in-house focus of behavioral health and psychiatry, and then some combination of telehealth, live video, phone, on-site providers trying to really support. But again, providers being overbooked, booked too far out, not able to schedule new patients. So access is a big issue, which we're finding all over as well. So thanks, Wendy, for your comment.
Yeah, agreed. Access has been a known challenge that unfortunately might be worse given the high demand with COVID. Great. Continue to let me know if there's questions along the way, but I think I'll keep going, and we'll switch just a little bit to look at COVID, not only because it's making such an impact on just how everyone is delivering care day to day, but as you'll see in just a moment, we are anticipating it really magnifying the issue that we've already uncovered in terms of behavioral health. And just a little bit about how Rubicon is thinking about COVID. When we first started looking at the pandemic, we started to think about it in sort of 3 phases. So the initial response, we were seeing a number of eConsults that were coming in, really asking about day-to-day operations. So PPE for staff, what visits should be canceled versus which visits should they keep? How do you start to manage kind of some care in the virtual setting and some care in the clinic? So we started kind of seeing a lot of support needed for primary care just on the basic day-to-day work of how do you deliver care. The second was that it forced all of us to go more quickly into virtual care, right? So there was a lot of questions coming in via eConsult that were saying, how do you look at an asthma exacerbation in a virtual care environment? What happens to the patients who need to come in but aren't coming in or aren't comfortable receiving care in a virtual environment? So we started working specifically, sort of specialty by specialty, on how PCPs could think about that. And then the third phase, which I would argue we're probably still in, is how do we start to get some of those patients back? Unfortunately, we're so worried that some high-risk patients are still a little hesitant to actually go back into clinic. There have probably been months and months where maybe chronic conditions haven't been managed effectively. And then we're also concerned just how do providers start to manage having some virtual care, but some clinic care. It just is sort of foot in two boats. That's an added complexity for the provider. And unfortunately, I think when we look at it, we don't see any immediate relief for primary care. What we were starting to look at is, could we start to identify trends from the eConsult volumes on our end, large increase in behavioral health. Also saw a pretty significant increase in just pulmonology, so questions about what needs to happen either to avoid COVID or for patients that actually presented that had pulmonary issues that then got COVID. And then a ton of work still happening just on eConsults to our infectious disease specialist. So thought we'd give you kind of a little bit of look as to the data that we were seeing in terms of how primary care is starting to manage through COVID. I think what we're really starting to worry about is just what does this mean long-term for providers. So number one, we held a CME webinar a few weeks ago where an infectious disease specialist, Dr. Megan Coffey, started really talking about what the complications she was seeing, and she kept referring to what she called long COVID. So a number of patients that were still presenting with symptoms even after the actual underlying COVID had resolved. And she was mentioning that there is a concern amongst her colleagues that we're just starting to see the tip of the iceberg in terms of long-term effects for those that have had COVID. As most of you know that are in the safety net area, this is going to continue to make and stretch just primary care. Vulnerable populations have fewer and fewer resources. It's just going to continue putting pressure on the system that was already a little stretched to begin with. And then we're tracking a little bit of that kind of volume shifting. So where patients aren't going to the hospital like they used to for basic concerns, they are now going to primary care. And primary care volumes are starting to rebound across the country, but we are anticipating that primary care continues to sort of have to absorb some of those volumes that they might not be currently staffed to do. And everyone very much focused and worried about kind of the elder care, just given the sensitivity and the acuity of COVID when it does present in those populations. But again, I'm going to switch back to our focus on kind of mental health and recognizing that, again, if it was a problem pre-COVID, it's definitely exacerbated now, and we're anticipating a pretty significant influx of demand and a need for primary care to start to actually take care of those mental health conditions within the walls of primary care, as opposed to going to kind of straight to referral. So with that, I think that's where we started to look at what needs to happen, and I'll get to that, but wanted to pause for any comments on just how COVID has changed how you think about practicing, or if you're seeing big upticks in mental health coming through your clinic.
And again, if anybody just joined late, feel free to unmute with any questions or comments, or you can put them in chat.
Yeah, this is Andy again. So I guess what we see is about 40% of the deliverable services happening via telehealth. There's natural barriers, that we're concerned about when some of the governor executive orders expire that have required telehealth. We're still seeing a severe impediment with TRICARE. That's for military families, and they're some of the most vulnerable populations. Those families frequently move. Telehealth not being available for them, they lose rapport with a clinician that they've built it with. So they may be in California, then they're in Alaska, and they say, sorry, no telehealth for that particular family. The military's been very challenging in being able to allow that for the services that we provide. And so I guess it's just, yes, it's been an accelerant for the current, moment that we're in with governor's executive orders being in place. However, many of those, may not continue. Health plans have certainly fought tooth and nail historically. I think some of them are now coming to the realization that it's good. But, cost containment's, always critical. I think you've talked about value-based and you do a lot of work, in those particular areas. So it comes down to the cost that they're going to pay. And, typically expanded access to care also means higher cost. And so, when we've, worked on some of the legislative components to advocate for commercial plans to fund for telehealth, we've heard a lot of outlandish things that, well, they're going to go on vacation to Hawaii and now we're going to have to pay for them to get services in Hawaii and, things like that. And we're like, no, what you're paying for is they're not going to regress. You're not going to have to pay for additional services. And so it's really an ultimate benefit from them from a cost perspective. And so I guess it's really hoping that people kind of see the big picture, the long-term benefits, but there are going to be some structural legislative components that have to be fixed if plans don't say on their own they want to go ahead and continue with this current model.
Yeah.
So to that, I guess my question is, do you folks engage in those types of advocacy, pieces? Because that's, I guess, my biggest concern is that, we're going to, again, we're all operating on these executive orders, even, likely from the federal government too, pushing for the expansion. But we do have a lot of barriers, from all plan letters that may not cover this in the same, broad component or look at it in limited ways that, it maybe video chats, the only thing that's covered because they're not expanding it to phone. And if the family doesn't have adequate bandwidth to be able to cover a video image, are you now not in compliance? And so there's a lot of those very technical pieces that is my biggest concern. And I guess what do you folks do, or do you have that, when we say kind of the roadmap, but that I guess takes the legislative advocacy, do you folks participate on that too, so that these gains that we've made that have helped so many people don't get lost?
Sure. Yeah. I mean, I'm happy to address it. I think the way we probably approach the advocacy part of it, Andrew, is via the session that you're probably working on today with the eConsult workshop. So I think we have relied on those organizations that really have a policy focus and are tracking with every sort of legislative change. We're supportive of that. I think in New York State, we've been a little bit active on some of the waiver programs they've thought about in terms of telehealth and better access to telehealth. So we are very supportive of those advocacy measures. I don't think we have a legislative arm working towards that, but we certainly try to plug into where those groups do exist, if that's helpful.
Okay. Yeah, no, that's helpful. Thanks. I'm part of a couple of those and had one of them. So it's just, many of these things are successful when there's momentum from an industry and multiple groups, rather than when it's one kind of going on their own, then it doesn't gain the same momentum. And that's kind of that critical mass component that's needed for a lot of these discussions. So I appreciate that you folks are involved in that.
Yeah, we would agree. I mean, I think we probably want to support just the broader industry of eConsults and telehealth and virtual care. So we will plug in wherever we find opportunities to do that, because you're right, the more voices that add, the quicker things start to get resolved. Great. Nicole, unless I'm missing something in chat, why don't I switch to kind of what has Rubicon started to think about in terms of expanding beyond kind of our core foundational eConsult service. And again, this was data that we were starting to track, again, pre-pandemic. So either the statistics have remained or even gone up slightly, but we were looking at undiagnosed conditions, 1 in 5. Pretty much across the board. And then for some of those that were actually diagnosed, they were certainly undertreated or didn't have optimal care plans in terms of their behavioral health condition. There's a number of sources that start to track what's the total impact in terms of cost to the patient. With those patients that have BH conditions costing significantly more when those conditions are not actually treated. And then the impact of treatment itself, when it is actually administered and you can do some control group comparisons, we have seen that it lowers the overall cost of care to the patient downstream because all their other chronic conditions are better managed. And it has multiple benefits and pays dividends at the end in terms of how we think about managing these patients. So what we started out to do was to say, well, we know that there's a number of behavioral health specialists, psychiatrists, subspecialties that we actually already had on our core platform. But what we wanted to do was start to think about how do you expand that so primary care starts to feel more comfortable treating these conditions within the four walls of primary care. So number one, what we did was really take a look at who are the psychiatrists we have on the platform and how do we actually increase the number of psychiatrists just so they can meet the anticipated demand. We also looked at some of the subspecialties that we had. So we had eating disorders, we had depression, anxiety. We started adding other subspecialties like insomnia, substance abuse. We wanted to make sure that we had coverage across all of those core issues that we were seeing present in our data from a behavioral health perspective. The other thing that was a big departure for us and a service that we are super excited about is I think some of the feedback that we were getting from primary care clinicians was while the text-based narrative was helpful, sometimes the complexity of these patients were really difficult to convey in that sort of text narrative format. So we ended up adding kind of a workflow component that's launched off of our dashboard that would actually connect via phone to psychiatrists. And Nicole mentioned it before, either an adult psychiatrist or a pediatric psychiatrist. This has been an area that has been extremely successful because I feel like we've heard two things from primary care. We felt like we were hearing they were able to give all the data and the information needed to convey the complexity of this patient. And then even the specialists and the psychiatrists that were actually on and part of these phone consultations felt like they were getting the level of detail they needed to make really informed and confident recommendations as to how to advance this care plan for the patient. We've also invested just in a number of educational dashboards because while we were getting feedback that PHQ-9s, for example, are very common in EMRs, just basic screening and diagnostic tools for all the other behavioral health issues that were being presented in primary care were sometimes difficult to assess. And certainly assessing the acuity and the severity of it was difficult without kind of access to better screening and diagnostic tools. So we've curated a means that lives within our platform so primary care can go and at least get an initial assessment of how difficult or how severe this patient is presenting. I think where we're wanting to go next, and I'll let Nicole speak about this in just a minute, is we actually want to expand on that and move into more of a comprehensive collaborative care model. So really integrating behavioral health with the work that the PCP is doing on a day-to-day basis and starting to treat the whole patient as opposed to the episodic diagnoses that we're seeing present. Just a quick look at, is there a question? Should I pause? So just a quick look at what we've done. We started working with a group of providers back in May, June timeframe. And I think what we were asking that group to do is really help us sharpen our pencil on what were these kind of discrete sets of services and what were the things that we would be able to expand within our platform. I think we were trying to accelerate whatever we could such that we could meet the demand that we were hearing from our clinicians across the board. So that sort of pilot group went in, started using the dashboard, the screening and diagnostic tools, really started engaging with the phone consults and started kind of giving us feedback as to what was happening. And we wanted to give you a little breakdown as to what we were seeing. You know, I think where we started this presentation saying that we felt like a lot of the mild to moderate behavioral health disorders were anxiety disorder and depression really proved out in the data. So a lot of questions coming in either via the phone or eConsults to help PCPs start to address that. I will point out during the other categories, we started to dive into this data. I think a lot of it and what some of our providers said is they felt like it was probably being driven by COVID. So we were seeing a big increase in insomnia and a big increase in substance disorder coming through post-COVID world. But these were kind of the breakdown, the aggregate numbers of how providers were starting to use Rubicon in treating their patients with behavioral health disorders. We also wanted to try to get a little bit granular in terms of what the questions were and then how they were being answered via the platform. And a lot of it was treatment optimization. So titration of medications and how do you actually start to think about a more integrated care plan. A lot, 25%, almost 25%, were initial initiation of treatment. So maybe they had been diagnosed but had not actually started with the treatment of that disease state. And then some more medication side effects that PCPs were trying to field with the patients they were serving. Just a little bit of feedback. I mentioned it before, but I think we've been looking at how providers have been using the expanded services. And I think where we want to go next, again, is sort of more in that integrated behavioral care model. So I'll let Nicole talk about that. But again, we've been tracking where we've actually been successful and are starting to try to track patient outcomes in terms of what we've already been able to put in place. Nicole, any thoughts just on the overall work that you're currently doing?
Sure. So as Sarah mentioned, when I came to Rubicon close to 3 months ago, the core product was really stood up around clinical decision support around psychotropic medications, more advanced screening tools, the eConsult and the phone consult. So it's definitely in our solution roadmap to enhance that core product to really maximize point of care decision support for PCPs and really have that platform be have the ability to go from screening to decision support and even care navigation and community resource connection as well. So we're definitely looking to continue to enhance that core product. But as Sarah mentioned, right as I came in, I started sort of presenting out to our clients and speaking directly with organizations who were in different phases of their behavioral health journey. Some were just looking to integrate behavioral health because they hadn't done so previously. Others had integrated a variety of models that really somewhat addressed patient needs, but had limited access and limited impact on sort of population health and was really a patient-by-patient approach. And others were had tried to implement something, but it wasn't going well. And so really, when I came into RUBICONMD, based on my previous experience and work, I really felt to support these value-based clients that we should be looking at the collaborative care model and really expanding our clients' ability to provide better access, treatment to target support, and at the population level. And so we're really looking, we know that there's organizations out there that already do collaborative care as their whole business or the majority of their business. So we're certainly not looking to replicate those. But we are increasingly find that physicians and their leadership are not wanting to go to a variety of platforms for a variety of services, go to each model that's been developed and it's already sort of a model that isn't integrated with anything else that they're doing intentionally. And so what we're building is a collaborative care model that's more modular and innovative to partner with our clients so that we maximize each of our clients' impact around what they already have or what they want to build versus what we can provide. So we're really building on the chassis of the ability to have our psychiatric consultants have a really great on-platform communication system and really some other ways to really innovate clinically and integrate clinically. So as Sarah mentioned, Rubicon continues to expand our comprehensive care model. We started with eConsults, obviously. We've integrated behavioral health. We're currently integrating pharmacy. We're looking at other clinical integration areas. So we continue to try to really provide a platform where a physician and their team can come and receive comprehensive care for their patients versus one specific thing only.
Great. Thanks, Nicole. And with that, I think that's the content that we were going to cover today, but we are happy to save some time for questions. I'm happy to answer questions on kind of the data that we saw in terms of behavioral health, and certainly any questions on where we're headed in the future. We're happy to take any suggestions if we're missing anything that we should be considering. So.
This is Carolyn Veal Hunter. If you can hear me, I was trying to type my question, but it was way too much to try to type.
Okay, no problem.
I'm more from a policy perspective out here in California, and with respect to the delivery of behavioral health, our California Code of Regulations require that before licensee, each time a licensee wants to provide services via telehealth, he shall verbally obtain from the client certain client information. Just reading the last example where that you were showing about the patient that had her initial conversation with the doctor, and then they did some follow-up information via email. The true reading of this would suggest that he or she, the licensee, should not have been able to continue to talk to that patient via email if they talked verbally, if they had not verbally gotten authorization to provide. So you might have had the consult with your doctor, then you might wanted to send something, email, text, or something to the doctor, but you would be in violation of this code section if you had not verbally talked to the doctor before you sent that question. So I'm just wondering, has anyone else seen that little nuance? And it's just it doesn't seem to, goes over beyond what looks like is required in section 2290.5, but just wanted to put that on the table.
Yeah, it's a great question. And just to clarify, so the quote here, the interaction was not with the patient, it was just the PCP to the psychiatrist. So it functions much the same as it would with an eConsult, except for this time it was an actual phone conversation as opposed to the text narrative eConsult. So it followed the same for this group was in Texas. It followed the same kind of legislative rigor that you would with an eConsult. Does that help, Carolyn? I didn't know if that was a point.
No, I guess what I'm saying, I'm thinking that what the feedback that you provided here, I think just supports the fact that I think that what we're doing in California may appear to be a bit too restrictive, because if each time you want to consult with your doctor, you have to get on the phone and verbally talk to them to say, yes, this is Carolyn, I'm this is who I am, this is where my address is, and this is where I physically am right now. I could be in a crisis and want to just quickly send an email or a text. All kinds of reasons you can be at work and not in a position where you could call somebody, but you would want to still connect with. And so having this verbal confirmation seems to be a little excessive.
Mm-hmm. Interesting.
Yeah, so Sarah, just to repeat what you said. So yeah, in this case, it's still a blinded consult. The psychiatrist doesn't know the patient's name or PHI. They're giving a consultation based on general information and giving the PCP information and emailing the PCP information that could help them with their patient and treatment decisions, et cetera. And in this case, I don't know if that follows the exact rigor that you're mentioning, Carolyn, about the PCP with the patient and the ability for the patient to access the physician in a variety of ways, whether that be text, phone, or other, in order to get the treatment they need. This is a little bit different because the PCP is consulting the psychiatrist to make sure they make the right treatment decisions versus, and that email information sent to the physician is around treatment and prescribing decisions and potentially, referrals to treatment versus something that would be emailed to the patient. But I hear what you're saying specifically around the consent it sounds like it's the consent with the patient around how they can receive care or receive information back from the PCP.
Right. Or whether you're reestablishing your patient setup each and every time you talk to them when they're already your patient.
That would be challenging in this environment, like you said, given that people need to access their PCPs in a variety of ways, and the in-person isn't available. So I can see how that regulation would be restrictive in this current environment. I think this is a little bit different because it's PCP to specialist communication around PCP decisions, but it's a good point nonetheless.
Okay. Probably something I want to follow up on with outside of this environment. Thank you.
Yeah, that makes sense. That's great. And I was just reading the chat. Wendy, I think you posted a great comment that you've taken over some of the eConsult submissions, and I'm glad it's helpful. We obviously are very bullish on that being able to drive positive change. And then some of the challenges with the no-shows on the on-site BH. I think, Nicole, you can certainly speak to this, but that has been a common theme of actual patients needing care but not actually receiving it. And our hope is that some of the virtual setup might actually start to address some of that no-show rate for those patients that are needing more consistent therapy options. Nicole, any thoughts on that?
I'm sorry, I'm trying to quickly read it. So Wendy, do you want to add some color to this just because are you okay speaking, or would you like us to address it in the chat? I'm trying to.
No, I'm fine. I can talk. In fact, that's never been a question anyone ever asked me. Chat Day has always had, well, for the last 5 years, they brought me on because I had done telehealth in another setting, and so they were wanting to do eConsults for a lot of medical modalities as well as live video and that kind of thing. So primarily in medical, and so we've had for the last 5 years. Pretty robust. It grew very quickly. We've got therapists, we've got psychiatry, we've got medical modalities, and the eConsult thing was like a huge change for everybody, just even in the medical. And so they asked the telehealth department to take that on. So that's what we've done just in the last month. And so everything I can, we send for eConsult, but I've spent a lot of time educating patients about it, and they love it. The idea that they can be addressed. When you first tell people, they go, well, wait, what? I'm not going to see somebody. No, you might, but it might not be necessary. And we can talk to you. We can get this through in 48 hours. So it's been awesome. We haven't really... For instance, I've always done tracking and stuff of no-show rates and things like that. Our telehealth no-show rates compared to the rest of the clinic have always been super low. And I'm not sure why, but that's just the way it works. And now what we have discovered, since the whole clinic has had to pretty much go to telehealth for PCP visits, for everything, so there's a lot more eConsult because I'm shoving those through. Consistently since the end of March, since everybody got trained up on it, we got the right equipment for every little cameras and everything, our behavioral health no-show rate has plummeted. It's been equivalent to the telehealth department. And there's a number of reasons for that. People are stuck at home, but it kind of removes, just like eConsult removes those. I mean, for years, since I started doing telehealth in, 2001, we see the same barriers today to telehealth and eConsult and all that we saw in the old days. Payers not paying, so you're kind of limited as to who you can get your patients in. The providers and I are constantly having to go, oh, wait, this one can't go because this is Medicare, or this one can't go, whatever. But then the other ones at the top of the list are, someone gets sick, they can't come in, or they, kid is sick, so now they can't come in because they're home with the child. Got a flat tire, no transportation, my ride flaked, whatever. All that's gone away because they're at home. But so that's been great. What it has done, though, is decreased accessibility, because all of a sudden our on-site providers, even though they're doing video and stuff, they don't have any last-minute cancellations. They don't, so it's like, oh, great. So we had to get yet another therapist on board for telehealth and stuff. So I'm really kind of super interested in terms of maybe a hybrid model of having eConsult for therapy and psychiatry be available, because, if I have a patient suddenly who has a medication issue and I can't get the psychiatrist because they're with me Monday and Thursday and it's Wednesday, and the PCP doesn't really know what to do and is a little hesitant to, because that's not their area of expertise. So this whole idea of that maybe a hybrid model where you're using both for backup and support or whatever. One is primary for one patient, but the other thing that we discovered, and I mentioned it here in my, my chat, is we haven't thought of this, because the tendency, there's always been a little pushback on, particularly in therapy, not so much psychiatry because that's more medication management, but with therapy, people, oh no, you have to have people on site, that people aren't comfortable with, it's better to have it in the room. And certainly for some people, that's true. But sometimes the therapist says, I like to hug my patients. Says, don't hug me. I'm not one of those patients. But interesting, I actually had one woman the other day who said, I've always been suggested to do therapy, and I just at last minute always cancel because I can't be sitting there in the room with somebody and telling them my deepest, darkest things. And all of a sudden, this removes that, whether it's eConsult or live video or a phone call. They're not, one person said, I'm not seeing the judgment on the face, or people try, I know they try to show me to not show their feelings, but I know they're judging me, and so for a lot of people, it's been much easier so that was a complete surprise. And so when I was tracking that and reporting that to leadership, they're going, oh my goodness, what a surprise. So, but the downside of it is that now we need more therapists and now we need more psychiatrists because everybody's showing up, so yeah.
It's a great point. You're right. So it's a challenge because, you need more of the actual therapist, but at least the people who need the therapy are getting the care they need, which is always what we're striving for, right? So thanks, Wendy. Those were great comments. Nicole, anything to add on it?
The only thing I wanted to add, Wendy, though, I thought those were all great points. And, keeping in mind what Andrew said earlier, that, virtual health and virtual mental health is very challenging for some populations that are more transient or need that clinical relationship, and they don't always have access to the technologies that they need to really maximize that relationship virtually. But having said that, I agree with you. I mean, the VA and other systems showed for many years that virtual care could meet or exceed in-person care. So in a lot of ways, this push of all of us to where we are has been advantageous for many, many patients. And I think we've all had to become creative around how we utilize our mental health resources. And some of the ways that the tenets of collaborative care, even if collaborative care isn't something that you're interested in or you've researched, the tenets of collaborative care, like using a psychiatrist for a weekly case review versus to see individual patients, is a great part of the model where a psychiatrist can lean in support of a PCP or a mental health clinician to really review a number of cases each week versus focusing on that direct patient care, which is one by one. Another aspect of the collaborative care model that's a great tenet is utilizing therapeutic staff to sort of function as a care partner, care manager role, where they decide, is this patient appropriate for our therapeutic program? Should we refer them out? Do they have other resources? Can I coach them to take their medication and feel better versus going into therapy? And I think, what health systems have found with traditional integrated models where they do have the therapist and the psychiatrist on site is, again, you can really make an impact on certain patients, but you can't necessarily handle the whole population. So really looking at hybrid and mixed models of how you approach your patients who need behavioral health services with the resources you have, I think is really, now's the time to be doing that with the influx and acceleration of virtual health, with COVID, et cetera. So there's a lot of different types of models out there, and I think everyone thinks you have to go all in with one, but it's great to try to mix and match patient approaches with population health approaches. And really, I think one of the biggest things for me as an MSW and a previous treatment provider that was really attractive to me about the collaborative care model, or any model that really focuses on outcomes, is I think, unlike in traditional medical care where we're looking at registries of patients with diabetes or COPD or et cetera, in mental health treatment, it's been missing to really look at the outcomes of patients. Are they really improving? Are we keeping them in a registry? Are they staying flat? And I think a lot of the barriers to that in the mental health world is funding for appropriate technology and support around really treatment to target. And in primary care, it's basically who has the time to really keep a registry, time and training to keep a registry of patients with mental health issues and really make sure they're improving over time with the referrals and the treatment, et cetera. So I think it's the time for all of us to really look at, what resources do we have, what's working and not working, how do we address patient needs while also looking at the population, and how might we innovate with what we have to continue to meet the higher demand. So really good points.
Yes, agree. I know we have just a few minutes before kind of the top of the hour, and I know most folks are going to be going over to the Blue Path, the sessions. So if anyone has questions, feel free to reach out to me or Nicole. Our contact information is here, but certainly appreciate everyone spending the hour with us. Hope it was helpful, and let us know if there's any additional questions. We're happy to field them.
Great. Thank you, Sarah and Nicole, and appreciate everyone joining us this morning. Just as some housekeeping, I have just posted a link to the next session at 9 a.m. in the chat box for convenience, and so feel free to click on that. and that should take you over to the next session. So again, thank you everyone for joining us this morning, and have a great day.